Next up straight away is Andrew, and Andrew's going to give us a summary clinical diagnosis and management of squamous basal cells and melanomas. With no further ado, my colleague Andrew, and it's over to you. And just by the way, speakers, you'll get a 5-minute a warning reminder. Please keep to time, okay?
I'm starting late though. Hi, I'm a GP. I've been a GP for 24 years. I've worked at Kofi Surgery in Warkworth, and I've done a lot of skin cancer. It was pretty rural when I first started, so there's a lot of opportunities to help patients by really cutting your teeth on people who would let you practice doing rhomboid flaps on their backs for free and things like that. I've moved now into full-time skin cancer medicine. I work with Chris at the Skin Check Clinic on the North Shore and Waitakere Hospital and the Rodney Surgical Centre in Warkworth. And I'm in the process of completing very slowly my Master's in Dermoscopy at University of Graz in Austria. So this is really more just, this is a lot of the stuff you already know, but it's just really to get you orientated before we get into small pictures of dermoscopic images that get confusing initially. So this is to give you what you know and a little bit more just to make yourself familiar with it. So we're going to be talking about BCCs, not superficial BCCs. Chris will be talking about that at a later date, but I'll touch on it. SCCs, and not SCC in situ or actinic keratoses, which are precursors to SCC. And SCC in situ, it's a bit confusing sometimes. It's also known as Bowen's disease and intraepithelial squamous cell carcinoma, or IEC. They're all the same thing, but I prefer squamous cell in situ. So we're not going to talk about squamous cell in situ and actinic keratosis, just full-blown SCCs, and then melanoma. And a useful little fact, which often gets not mentioned very frequently, is, by the way, my kids' text language. 5% of lentigo malignas, which are probably MISs, progress to lentigo maligna melanoma, which are invasive melanomas. And so only 5% progress, so that's an important fact. And similarly with SCC in situ, only 5% of those progress to SCC. So what will you see in day-to-day practice? You'll see BCCs mainly, 70%. Squamous cell carcinomas, 25%. Malignant melanomas, much less. I wonder whether that will be increasing with the surge in the melanoma in situs, but the current stats are 4%. And others, which you don't really need to know about, but like some Merkel cell tumor, which are very aggressive, and when you see one, you know it's not nice, and you'll refer it off or cut it out. Basal cell carcinoma, as I say, is the most common type of skin cancer. It rarely causes death, but in theory it can do. But it can be very problematic, so you get nasty sclerosing BCCs that are difficult to see and in difficult areas around eyes, nose, and mouth. And if you delay the diagnosis, they can be very difficult to get rid of without significant morbidity. Now, there's a number of types of BCC, and that does get confusing. The literature, I'll leave that down there. The literature doesn't make it very clear, but my simple way of categorizing it, you've got nodular BCC, superficial BCC, and sclerosing BCC. Now, nodular BCC have a number of more aggressive forms, and that's micronodular, microcystic, and infiltrative. So you just need to be aware when you get the histology report, you look to see if it's a little bit more aggressive. If it is a little bit more aggressive, you need to be sure of the margins. And if it's in a tricky area and it's a narrow margin, you might want to think about referring them on or doing a further excision. Superficial BCCs, as I said, we won't be talking about that today, but I'll just touch on it. But they're normally flat pieces of red skin. And then the sclerosing or morphic form of BCC are the ones that catch you out. And I can remember seeing a patient with a scar on his forehead for a long time until the penny suddenly dropped. And how'd you get that scar one day? And he said, what scar? Oh, no, I've never done anything. I've never had any injury. I don't know, it's just growing. And it was a sclerosing BCC. As they get bigger, they become more obviously not right, not just a scar, but initially they can just be a scar that the patient can't recall any trauma. And they can have very significant peripheral and deep subclinical disease, and they can be very difficult to treat, especially on the face. Rarer types, again, we don't really need to go into them. Basosquamous cell carcinomas, that's half and half of a BCC and an SCC, and they are potentially quite aggressive, but you're going to spot them as, you may call it a BCC, and it comes out as this, or an SCC, but you're still going to spot them as something that's a problem. And fibroepithelial tumours of Pincus I don't think I've seen one of those, but I'm sure maybe I have, but they not recognise them as anything other than a BCC. Causes of BCC, we all know, is the sun, but there are other causes, and you will see patients who've had a renal transplant or such like, and they're at more risk of getting BCCs and SCCs because they're immunocompromised. And there are other rarer causes. You get the odd genetic disorder where people just grow BCCs, and if someone's poisoning you with arsenic, you might start growing more BCCs as well. So this is just a simple, straightforward list, selection of slides of BCCs. So this is the common BCC. It's got a sort of translucent appearance, rolled edges, and you'll see some ulceration in the middle and telangiectasia. And I'm sure everyone here will be familiar with that appearance. And this is another BCC on the corner of the nose, just abutting the nose next to the nasolabial region. And if you look at it a little bit closer, you can see some arborizing blood vessels, and you might see some little dots here and here, and they are probably blue clods, and we'll look at those with dermoscopy, and you'll start seeing those in dermoscopy, and once you start seeing them in dermoscopy, you'll probably start seeing them more often clinically. And that's another BCC. You'll all recognize that in a tricky little place. And that's a BCC, and how could you tell it's a superficial, not a superficial or a nodular BCC? If you look at the dermoscopy there, and we'll be obviously going into this in more detail, but there's a blue clod and vascular veins. That's an invasive BCC, and it's not a superficial one. So ideally you cut that out, and that helps you make a decision in that situation. Another BCC, easy stuff. That's in a nasty location, a large BCC, again with the arborizing or branched vessels and the translucent appearance. Another small nodular BCC, lower eyelid. And that's a pigmented BCC. And again, on first glance, when you first saw that patient, you might be worried about a nasty nodular melanoma. But if you put your dermoscope on that, you will know that it's a pigmented BCC. This is the sclerosing scar-like one, which is very difficult, and you'll spot them from time to time. And if you can't get a history of trauma, you need to be thinking about whether it's a sclerosing one. That's not in a particularly challenging area, but around the nose and the eye or the lips, more important to pick them up early. This will grow slowly and will change without any obvious reason. So just thinking about that. And this is obviously a more advanced sclerosing BCC, and that's going to be really difficult to get rid of and cause significant cosmetic issues. And the subclinical disease, I think on average in one paper they said the extension beyond what was clinically obvious was about 7 millimeters on average, so some were more. So these can really get entangled in the nerves and deep structures. And this is just a standard nodular BCC, and again you might well see the blue clod there possibly, and you'll see some vessels and it's translucent. And as you start using dermoscopes, you'll find it more and more easy to make a definitive diagnosis just clinically, which you probably can do already with this. And the point of that slide is if you leave them, they just get bigger. I had the patient that was a great friend, and I did my surgery on him because he just had BCCs and SCCs all over him, and I'd always do it for free, and he would let me practice my different tricks on his back. He eventually was getting very frail, coming towards the end of his life. He had a little BCC or maybe an SCC on his neck, and I thought, leave him alone, he'll be fine, I don't need to do that, I'm doing it because I want to do it rather than benefiting him. He then got admitted into a rest home, and so I was no longer his doctor. I didn't see him, he lasted for another 3 years, but I saw him just before he died, and this horrible ulcerated mess on the side of his neck that was the bane of his last days, and the nursing staff were worried it was going to go through his carotid, and he's going to bleed to death, and it would smelt, and he was too old and frail for anyone to do anything about it. The lesson I took from that is, just because it's small and they're elderly, it doesn't mean you don't need to deal with it. Not always the case, but I think you need to think about what could possibly happen. I like the lights lower if we can, but... Yeah, I'm happy with that behind me as well. Anyway. Treatment of BCCs, we all know the way to treat BCCs is to cut them out, and the sooner you can get them, and you can get them a lot earlier if you use a dermoscope. And we want to get 3 to 5 millimeter margins. And that's variable depending on where it is. If it's on the back, you can get generous margins. If it's on the face, you're going to have to be more conservative, but the more aggressive it is, the larger the margin. And one thing that's a point of confusion to lots of people is, what does the margin mean? 3 to 5 millimetres. You get the histology report back and it says 3.2 millimetres, and you wonder, if you were aiming for 5 millimetres, did you really get 5 millimetres? All the studies are based on clinical margins, not histological margins. And when you take the skin away, it's losing that surrounding force, and it shrinks, and it goes into formalin, and it gets smaller. Now, there's lots of variables as to how much it will shrink. It will shrink from maybe 50% down to 20%. The shrinkage will be 50% or 20%. So a rule of thumb, 3.5 histologically is possibly about 5 millimetres clinically. But you've got a lot of issues when you're trying to balance these things. But at least if you're thinking about the difference between clinical and histological, you'll be on the right road to be thinking about whether what you've done is adequate. And if you can't cut something out with, so you can't use surgery, then there are other things. And FUDEX or Adara can treat nodular melanomas. Not that you would do that as a first choice, but if you could give it a go. Obviously, liquid nitrogen will help. Radiotherapy is definitely something for elderly people with a large SCC in a difficult place and they couldn't possibly manage surgery. Then radiotherapy is always something to consider. And you can consider radiotherapy as well if you cut out something that you haven't got good margins and you're worried about it, and you can shoot the area with a bit of radiotherapy. And I've found whenever you refer these patients off, they're very happy to see them and treat them. So this is an image of a BCC on a nose, and it was obviously left for a long time. So what I've done there is I've marked around what I can see, and I put my threefold magnification on, bright light, and mark the dotted thing around to see if I've got the whole of the BCC, to mark what I can see clinically, and then I put my dermoscope on and have a look to see if any of the tumour that I can see with the dermoscope extends beyond that line. So this is the next one, which gives you that translucent appearance, the blood vessels that are arborizing, and then I've drawn a margin beyond that, 3 millimetres there or thereabouts, of clean tissue, and then that's what you take out. And so the dermoscope, if you use it well, you can avoid your incomplete excisions very well. So we're going to squamous cell carcinomas, and they're also, so the things we're not talking about today are actinic keratosis, which are also known as solar keratosis, or SCC in situ, which has got 3 different names, Bowen's and IEC. And they're precursors, and Chris will talk about those. But we'll talk about SCCs, and they often present as a non-healing sore or a volcano-type appearing thing, which is often called a keratoacanthoma, and that, I think, is reasonable to think of as a subtype of SCC, but there are different classifications, but subtype of SCC that grows very rapidly and can then also disappear, but you're never sure whether they're going to, and they're quite aggressive, and the ones that disappear often leave a bit of a gnarly scar, so cutting them out is a standard way of managing these. As you know, SCCs are more dangerous than BCCs. They can metastasize. BCCs in theory can, but rarely do. And if they're located in high-risk areas, the scalp, the ear, the lips, the eyes, the lips, those are much more likely to metastasize. And there's aggressive subtypes that you'll see on the histology report. We're getting more and more synoptic reports like the melanoma reports, which will give you factors that suggest that it might be high risk, such as the original size, which is greater than 2 centimetres if it infiltrates more than 4 millimetres, if it's got perineural invasion. These will all be pointed out for you at the report. If it's undifferentiated, it's much more aggressive than a very well-differentiated cancer. And the purpose of that is if you've got one and you've got a 2 millimetre margin and it's come from a 70-year-old man's neck, ear, so it's a high-risk place with high-risk features, you'd want to take a larger margin and also consider radiotherapy. So I'm just repeating that on that slide. And this is what we're all familiar with, the actinic keratosis. The first grade, grade 1, is you can feel it but you can't see it. This is more grade 2, where you can see it and you'll be able to feel it. And then grade 3 is the big horny keratin lumps. And we all know how to treat these with liquid nitrogen, Aldara, Effudex. And it's a precursor to SCC. And this is what SCC looks like. It's a non-healing sore that's very different from the classic BCC look. And here's another one, a non-healing nasty sore that you can see is going to cause that patient lots of problems. It's probably going to be difficult to get clearance without very careful planning, and it's probably going to be a very aggressive tumour, and there's going to be significant morbidity as far as cosmesis. You'll probably need a skin flap, a graft or a flap. And that's the keratin horn, whether that's a keratoacanthoma or just an SEC. But it's in a high-risk area, and the histology is going to be very important, and the margins, your clinical margins, not your histological margins, are going to be very important. And that's another SEC. Again, it's a non-healing sore, and it looks nasty, and it's in a high-risk area, probably more than 2 centimetres in diameter, and it will probably be more than 4 millimetres in depth, and it will probably be poorly differentiated, and it may have perineural invasion, all the risk factors. So these are the ones that if you don't manage thoroughly and correctly, even though you've cut it all out and it looks fine, these are the ones that will get you into trouble a few years down the line because they'll metastasize, and on hindsight, you will be seen not to have managed it aggressively enough. And here's a keratoacanthoma type 1 on the left, and just a sore on the rim of a pimmer. They're both SCCs. And this is another SCC on a lip. And so the risk factors for SCCs, again, the sun, and obviously immunocompromised people again, and they tend to produce more aggressive SCCs. Scars and chronic ulcers, sometimes the chronic ulcer was actually an SCC all the way along, but you can actually develop squamous cell in a chronic ulcer, and smoking is a risk factor for SCC as well. And again, SCCs are easily treatable. I haven't checked the slider. I'm not used to that. I can't read the slider from here. Does anyone want to let me know if there's any burning questions? There's lots. Should I stop for a moment and answer the questions? Could? Yes, please.
So a really tricky one. Is it dermoscopy or derma?
Is it dermoscopy or dermatoscopy?
Oh. The International Society of Dermoscopy, which is what their name is, say they prefer us to use the word dermatoscopy. So take that as what you mean.
Right, well...
Next question.
Yeah, we'll move on because this is just as popular as the last one. Do we know how often AK progressed to SCC?
I don't. Cliff probably does.
Very, very rarely, probably less than 1 in 1,000.
Next question.
There was a question about slides, and we'll have them on the website as we go through the weekend. We'll start adding those if people want presentations. There is a hidden question, which I'll just answer very quickly, for charging stations. There is one on the way, and it'll be down the far end of the room by the water station. Back to educational things. So if those sites more at risk of metastasising, what percentage of those turn to metastasising?
I think worst case scenario, but again, I would bow to Cliff's knowledge on this, but the very aggressive ones, up to 30%, so they can be quite serious. Would you agree with that, Cliff? Of the high-risk SCCs, how many do actually metastasise?
Well, the point is that of SCCs in general, 1 in 1,000 kill the patient. In Australia, we have 400,000 SCCs and 400 deaths. The high-risk ones, it varies, but a poorly differentiated SCC, probably 10%, 20%, depends how deep they are. So 1 in 1,000 for SCCs in general, and much higher for poorly differentiated. But in Australia, more people die of well-differentiated SCC than poorly differentiated because there are so many more well-differentiated SCCs.
So 10 to 30%, say, of the nasty ones can potentially metastasise. So it's significant.
Can Mohs surgery be used for Morpheus BCC?
Yes, and that's a strong indication.
Okay, I'm going to struggle with this word too, so some help please, audience, you've been great. Is it not possible to wait for
Keratoacanthoma.
to resolve, or do they all need excision?
You should excise them all. Sometimes by the time they get to surgery, they may have resolved, but you will be very brave because they're rapidly growing, and sometimes even a keratoacanthoma can metastasize, and when you leave them and they regress on their own, they'll often leave a scar. So yes, you could, but I think you should be thinking about cutting them all out unless it's gone on its own before you get round to it, or it's a very difficult situation with an elderly person at the end of their life. Generally, yes, you should cut out keratoacanthomas.
How can you say only 5% of LM progress when they cannot be studied? Thanks, Clough.
That was from Clough.
Oh, Clough. Well, you tell me how you can say. Well, it's what I've read in the literature. I don't know how they came to that.
Yeah, it's never been studied and it can't be studied because no one can leave lentigo maligna to see if they progress. So it's never been studied, and we can't assume that any lentigo maligna will not progress. If it happens, it hasn't been studied, and there's no way you can tell which ones would not progress.
But you'd agree the literature does say 5%. Not scientific, textbooks.
Well, it's not true.
Okay. You shouldn't invite international experts when you're talking to you.
Boxing match at morning tea time. Hey, Andrew, last question.
No, Cliff's right.
Last question for now. Are morphic BCCs prevalent than other BCCs if patients are on biologicals?
On what?
Biologicals.
Biologicals.
Yeah, I'm reading verbatim, sorry.
Sorry?
As the dermatologist who actually prescribes biologics, squamous cell carcinoma is more likely because it's slightly immune suppressive to be on a biologic, and immune suppression increases the rate of SCCs way and above over BCCs. But don't forget that overall BCCs are more common. Morphic BCCs are seen on the face. They're not particularly more common in immune suppressed people than other people, and they're an uncommon presentation.
Thanks, Amanda. Okay, hope that's helpful. It's great to get the interaction, so please do ask the questions. Need to get binoculars. Okay, surgical management, you remove them when you can. The more aggressive and larger ones, you need to think very carefully about the margin and whether you want to refer them on. And think about post-surgical radiotherapy and regular follow-up. Melanomas can look like mole or freckles that develop over months. Slow-growing Hutchinson melanomas that we were just talking about, lentigo malignas, can evolve and ignore that 5% into lentigo maligna melanomas. So there's those two types, the slow mole, the Hutchinson freckle, and then the very fast-growing nodular melanomas, which can appear in weeks, and those are the ones that kill New Zealanders, and those are the ones that we often, not often, but unfortunately I've seen a few times, and it happens, and it's terrible for the GP as well. They say, no, that's fine, it's a seborrheic keratosis, and we're going to spend a bit of time on looking at that, because it's very easy if you put a dermoscope on to say that's not a SEB-K, therefore it could be a nodular melanoma, and these are the ones that you see. I've seen a patient who was reassured on 3 occasions by 2 different doctors, who was in his 40s, ended up mortgaging his house to pay $200,000 for Keytruda, and still died, and left 3 kids and a wife with a massive debt. And that GP would feel absolutely awful. And no one's been teaching this stuff in medical schools. So this is something that we really want to hammer home, how to diagnose a nodular melanoma that looks like a seborrheic keratosis. This is the slow-growing freckle, and the patients will often say that's been there forever, and it's a bit like looking in the mirror in the morning, you haven't changed until someone shows you a picture of how you looked 10 years ago. They look at this freckle and they don't see it change, but it is a superficial spreading melanoma, an MIS, I'm not sure which one it was. And that's the lentigo maligna. And that's the nodular melanoma that you're going to see, and you're going to go, that's not right. You may not make the diagnosis of nodular melanoma, but you will remove it, so that's going to be straightforward. That one can look like a seborrheic keratosis, and if you put a dermoscope on it, you'll see it's not a seborrheic dermatosis, it's a nodular melanoma. That one is a nodular melanoma, and you'd pick that pretty easily clinically, and so's that. And then I'm just giving you a feel for things, and that's another nodular melanoma. could be mistaken at a glance as being something else, but no, it's nodular melanoma. This was a patient that I saw that the GP picked up and was referred to the hospital system, and I do work for the hospital, and he picked it up as a nodular melanoma. I saw the patient was adamant it had been there for years and wasn't changing, was quite dismissive and a little bit put out by the fact that we were going to cut it out. She didn't think it was necessary. You put a dermoscope on it, and that's what it looks like. So it's got that bluey black area around here, and there's nothing in that that tells you it's a seborrheic keratosis, and you'll learn more about how you diagnose seborrheic keratosis dermoscopically, and if you put a scope on it and you can't say it's a seborrheic keratosis, then you need to think about nodular melanoma. Oops. And this is one that Richard Martin, a melanoma surgeon, just sent me last week, and that looks pretty benign. It's all symmetrical and tidy. I don't know the history, but you can almost see white clods in there, which are the miliary-like type cysts. And when you put a dermoscope on it, that's what you see. It's not a SEB-K, that's a nodular melanoma. We haven't got the histology back, but Richard will be here on Sunday, and maybe he's got that back. But regardless of what the histology is, you need to cut that out. And in hindsight, you might find out you're wrong, but I doubt it. Now, margins, clinical margins are based on, as we've said, clinical margins are what the guidelines are based on. And that's the lesion, that's the distance between the edge of the lesion and your excision line. Histological margins are not what the guidelines are based on. And that's the edge of the lesion to the edge of the specimen histologically. And you've got to take into shrinkage in that. So when tissue is removed from the face or areas with high tension, it shrinks, and that's the key. Now, the complication gets in when the guidelines are based on clinical margin. You get reports on the histological margin. You know the shrinkage, so you can take account for that. But you don't know how much subclinical disease there is. So you've got to weigh up those factors, and there's no straight and easy way to sort that out. If it's a very clearly demarcated lesion, you'll feel more confident. If it's not so clearly demarcated lesion, or something like a melanoma in lentigo maligna that typically has subclinical extension, you're going to have to work pretty hard to make sensible decisions or get advice as to whether you've done a significant enough job. So really what you're trying to do is work out, is it due to the shrinkage or is it due to subclinical disease? And this is obviously most important with melanomas and high-risk SCCs. So the slam dunk scenario is you do the 2 millimeter margin, which is the guidelines for any lesion that you think could be a melanoma. And if that report says the lesion has been completely excised with 1.5 millimeter margin, which is due to the shrinkage because you did a 2 millimeter, then you know you've got it all. So then if you do a clinical excision with 5 millimeter margins, then that's it. You know you're safe. You've got it all. And it doesn't matter what the histology reports. If it comes back as 3.2 millimeters, you know clinically you took a 5 millimeter. And you should be going down to fascia wherever possible. So this is the things, and this is easily accessible. And all these slides will be available afterwards, so you'll be able to look at them on the website. But that's all pretty standard stuff. And then just quickly run through the benign things. So solar lentigo, sunspots, flat brown sunspots, seborrheic keratosis, many of them evolve from solar lentigos, cherry angiomas, blood blisters, and dermatofibromas. They're all benign, and they can all masquerade as melanoma. So it's good to know what the dermoscopy of these things look like so you can exclude them from your worry list. So that's a chap with lots of solar lentigos on his back, and it's a very common sight. And that's the one with solar lentigos on her face. And that's another one with solar lentigos on her face. And that's the beginning of a lentigo maligna. Now, there are subtle differences. You can probably spot it, but you wouldn't be 100% confident. But with a dermoscope, you'd be a lot more confident. And that's lentigo maligna that's advancing. And these are some more solar lentigos with seborrheic keratoses. Is that a bell for me? No. And we're all familiar with that, seborrheic keratoses. And that seborrheic keratosis, they're stuck on appearance. There's a couple of angiomas in there as well. And we've all got patients that have this sort of thing. That's a dermatofibroma. They're benign tumours. They can be problematic. They're often on the legs of women. They can rub on the shoes, or women more often complain about they catch it when they shave. But if they're not problematic, you don't need to take them out. And one of the telltale signs is if you pinch it, it's adhering down below, so it dimples inwards. So it's a firm nodule and dimples inwards. So clinically, it's probably the easiest thing to diagnose. Dermoscopically, you'll confirm that. Now, that's obviously a more difficult one, but apparently that's a dermatofibroma. It's something I borrowed from another site, which is up there. But you'd obviously be worried about a nodular melanoma, so you'd need to look at it with a dermoscope, and you'd want to make sure it had a dimple and a firm appearance to it, and a good history. And we'll go through this, but that's a dermoscopy of a dermatofibroma, a scar in the middle with pigment network around the outside. And that's another one, and you'll get very familiar with these images. And that's another one, and we'll be definitely going through this a lot. Cherry angiomas, we're all familiar with those, and they have the red clods, which is like that. Now, this is just a simple example. We're just about finished. On the left is a superficial squamous, actually I'm not sure, superficial BCC or squamous cell carcinoma in situ. Dermoscopically, you can confirm that. On the right is dermatitis. So, bottom line is you wouldn't have any idea. Clinical context may help you, but just looking at those two pictures, vastly different diseases, but you need a dermoscope to distinguish them. That on the right is psoriasis, on the left is a superficial BCC, and you need a dermoscope to clarify. Clinical context will add a lot, but a dermoscope will be also adding a lot. And this is my last slide. This was, and I've been saying, don't listen to patients who say it's not changed, it's been there forever. This was the opposite. It was a son of a patient of mine. I'd taken an invasive melanoma off her knee a number of years before. He came rushing in without an appointment, obviously distressed, saying, and it's a terrible picture, sorry, I wish I'd got a better one at the time. I've got this black thing that's just appeared on my leg. It wasn't there yesterday. And of course, I'm thinking, of course it was. You just noticed it yesterday. But then when I put the dermoscope on it, that's what it was. So he'd been with his horses and running around in the field, and he's got a tick. And you really, I thought it was a black mole, I swear. But obviously I was just not thinking of ticks at the time, but maybe I would have done. So the dermoscope adds massive amounts of confidence to your diagnosis. Any further questions?
Yeah. Are we on?
Sorry?
Yeah, so can you see the screen bigger in front of you, Andrew? We've made it bigger.
Yeah. Yes, I can now, yes. Why,
there you go.
why not just a
we've
5
got 10
millimeter
minutes
margin
left.
immediately when removing a melanoma rather than 2 millimeters? Cliff and I have been talking about that a lot. The issue is if you've got the diagnosis wrong, and it's a 0.8 millimeter invasive melanoma, then that patient would benefit from sentinel node biopsy, so that if there was evidence of spread, then you could have regionally directed therapy for it. Now, if it's 5 millimeters, apparently it disrupts the lymphatic flow, so you're less likely to get as accurate location of the sentinel nodes. Now, Richard Martin who's talking has told me he doesn't think it would make much difference, but the literature quite clearly states 2 millimeters, otherwise you may disrupt the lymphatic drainage. And Amanda's got something to say to on that.
The provisional standards for melanoma require you to remove it with a 2 millimeter margin. So if you're doing anything else, you're outside the standards.
The other thing is it's not just 5 millimetres peripheral margins, it's down to muscle. So if you do that, you really disrupt the lymphatic drainage. So not so much just the 5 millimetre, but if you're excising it as a melanoma and don't want to go back, you have to go right down, not to the muscle fascia, not including the muscle fascia, so the full thickness of the fat. Now that's also a really big excision if it turns out to be benign. So there are two reasons not to do the wide, deep excision straight up.
I'm not sure what a biological is. Amanda, what's a biological drug?
The biological drugs are these ones that say UMAB and IMAB and ZUMAB and names like that. They're a modern form of monoclonal antibody produced from biological tissue.
Sorry, man, you need to hold the microphone a little closer.
I could talk all day, but we haven't got time for that. They're very expensive.
can you please list the risk factors which make an SCC high risk? Well, you look them up easily. I'll try and remember them. It's in the T-zone in particular, from ear, eyes, nose, lips, but also scalp. So that's the location. Greater than 2 centimeters in diameter. Equal to or greater than 4 millimeters in depth. Perineural invasion. Moderate to severely undifferentiated. And there are a few others I'm sure Cliff will be able to add to, but lymphovascular infiltration. But these are things that when you get the report and you can't remember it, it's listed there for you, and Google is great for helping you with these lists of things. You don't need to memorize them all. But as long as you're aware of it. How to remove a cherry angioma if it's troublesome. I wouldn't shave it. Maybe you can, but I think it'll just bleed. I'd probably usually use a punch excision, but you could do a small elliptical, but most of them would probably fit in a punch, and that's probably the easiest, and we can teach you how to do that later. How long does it take for a keratoderma to resolve? 6 to 12 weeks. Any more?
No, not at the moment. We have got 5 minutes. If anyone else wants to ask another question. Oh, one just popped up.
Yes. I think that's more sort of when you have numerous of them, but yes, essentially the same.
No more questions?
Oh, one over here.
If you've actually got the histology of a high-grade at-risk lesion,
Sorry, just a minute. We just hold that. If we don't have the microphone, it doesn't work.
I just want to know, housekeeping-wise, can you, as a GP, refer directly to oncology to do...
Hold it close to your mouth and everyone
Can
here.
you, as a GP with a high-risk histology report, refer directly into radiation oncology, and they'll go and arrange...
Yes, they
You
will.
don't have to go through a specialist.
No. Sorry? Okay, yeah. Okay, thanks everyone. I hope you enjoyed today. We've been working very hard on getting it, so it's really aimed at a very practical level for you guys. So talk to us and give us feedback, and we'll try and improve things. So you had a question?
Oh, yes,
Can you shout?
AK, I was reading an article somewhere that every AK will eventually become an SCC in time, and I guess I'm trying to find a metaphor to think about it. Is it a bit like CIN? Should we be managing everyone aggressively, or
No,
just...
no. Most AKs, as Chris mentioned, very few of them, 1 in 1,000, will go on to become an SCC, and you'll get plenty of warning because it'll become thicker and gnarlier and problematic. But it is nice for comfort, for appearance, and to reduce the likelihood of the ones going on to treat AKs.
What
But
about with changing age structure of population?
it won't increase the frequency of transition, no. So I think most AKs will stay as an AK. I've read at some stage, and I might be correct on this, but many of them, 20, maybe 30%, will actually resolve on their own if their clinical situation improves, so they protect their skin and they're healthy and so forth. Yeah.
Thanks.
Great. Now, we've got an advertorial coming up, so we've got to make it clear that it's important. I think you'll all find it very useful. But one is Brent from Esteem, who's going to talk about the dermoscope you're going to be using and just show you the selection of options. And the other one is from Derm Engine, and it's a wonderful piece of software that there's nothing else to compare with. I could have presented it, and then it wouldn't be an advertorial, but I think they'll do a much better job at presenting it to you. So I'll let Chris introduce. Thank you.
That was great, Andrew, and thank you very much for all that. Well presented general practice things that we do, and skin cancer is huge in this country. It's a big part of what you do every day, and it's very good. AKs, I treat them. I follow the Austrian Iris Aldac approach. They are precursors probably. It's slow and things, but it's good to treat them, and later we'll talk to you a bit about the new field therapy that's there for that. So you have to think of it as a continuum, even though it's a low rate going on.